I'm sharing the slides, so y'all bear with me. Hopefully we won't fall off or anything like that. So when you're ready to start recording, I guess I'll share my screen first and get the slides up, and then we'll start the recording.
Recording has already started. As soon as you said it, I started the recording.
Okay, no problem. No problem.
Well, top of the morning.
Can everybody see the slides? I'm sorry.
Yes.
Okay.
I can't. Oh, Oscar, did you want to take the mic? Oscar, go ahead.
Okay. Yeah, that's okay. Welcome everybody, and we want to thank you for your participation in your hands off on the 2025 Regional QIP kickoff. This year, 25-26, it'll be very interesting and more a lot of moments for learning and increase the learning curve basically, because we gonna drop some ideas, some project that we can be working on, but will be your decision based on your capabilities, resources, and all of those stuff. More convenient and facilitating everybody's life. So again, thank you very much for joining us, EHC team, CQM team, Ryan White, and pass the ball to AJ.
Good morning, everyone. For those who don't know me, I'm AJ Johnson. I am the project officer for the subrecipients on the EHE side / grants coordinator, many titles, but I'm a senior program. I'm the senior program monitor. I do want to give a shout out to CAN Community Health, Oscar, who's new for us. So we definitely want to give them a warm welcome. Shout out to CAN Community Health and all the other RIY subrecipients who I had a chance to recently meet and work with. Definitely a pleasure working with you guys so far. And then let me see who else. This is a staff, CAI. I think I heard somebody say that here. Any AS staff that's here. And then we also want to show our enthusiasm for this next regional QIP. So I'm gonna pass it over to Regina now.
All righty. Thank you so much, AJ. Good morning, everyone. Next slide. We're advancing. Just want to orient everybody to the team's features. But first, we want to get to know each other. So I saw some good mornings in the chat, but if you would please enter your name and your organization in the chat, please. And then we also would like to know, like for you to enter either Yay Spring, if you're enjoying the flowers blooming and enjoying the warmer weather, or Boo Spring, if you're suffering like me with the allergies and all the elements that are in the air, and if it's too yucky for you right now. But within the Teams platform, if you'd like to change your view of how you see these slides, the slideshow presentation and the attendees, there's a little square box across, it should be across your banner there that says view, and then you can drop down, it'll drop down and give you some options of how you'd like to view that. We also ask that you place yourself on mute until you're ready to chime in. We highly encourage the use of your webcam. We want to see your smiling faces, but if it's not possible, we understand that as well. And use the chat room to interact with your colleagues and our team. Especially if you have any questions and just want to drop them in there, we'll address them as we can. This meeting is being recorded, so it'll be available in the toolkit after this meeting, especially for those if some of your team is unable to attend, it will be made available for them to view later. And now I will turn it over to AJ.
Thank you, Regina. So our learning objectives for today, we want to be able to describe the expectations for this year as far as the both QIPs for the provider organization at the AA level. We do encourage you guys to be interactive, ask questions if you have a question. There's no dumb questions. I think we know that, right? So we're all professional. Please ask so we can and get it answered. We don't want any confusion as we move forward. So we're going to also review the model for improvement, discuss the L2C stigma reduction and trauma-informed care QIP options and examples, discuss how L2C can solidify rapid start in Dallas. And then we're going to identify the next steps that's going to lead us into our June webinar. But in order for us to get that started, we have to go over our toolkit. I'm going to pass it over to Tavion for that.
I appreciate it. I am Tavion Segal, part of the CQM team. And within your toolkits, these are what's provided for each participant. So you'll get a copy of the presentation slides for today. You'll get an updated PDSA form in which Angie and I have been refurbishing, and we will be releasing that within the next quarter. A root cause analysis form, stigma screening tool examples, trauma and care documents, as well as rapid start literature. Thank you. We can transition it to D'Angelo.
Yeah, here I'm just going to go over a few of the intro to 2025 QIP. So we know people living with HIV are disproportionately impacted by stigma as well as trauma, and this negatively impacts their quality of life and health outcomes. Now, because of this, the two areas we added to the Ryan White and both EHE RFPs / contracts this year, which led them to being the QIP options. So we have the trauma and trauma by stigma, and then trauma and stigma, my bad. And then we're continuing with our linkage to care as well, just wanting to improve our health outcomes there as well. So we'll have 3 different options this year.
All right, thanks, Dee. So this year is a little bit different because previous years we selected the QIP and everybody kind of did the same thing. So this will be the first year that we kind of have an option that you'll be able to choose from the 3 options that Dee just mentioned. So just briefly, the linkage to care option is for this year is the linkage to care in 7 days for the OHS providers. For the support services, you're going to verify, just like before, verifying that your clients their clients that are new to you are in care for HIV services. And then we have the 2 new players, stigma reduction and trauma-informed care. So these are across Ryan White and EHE providers. A second. So I'm going to talk about option 1 just a little bit, the linkage to care option. So this is primarily the same as before. You're going to link newly diagnosed HIV clients into care within 7 days, except we're going to not have that bacterial STI piece, so that dual diagnosis. So just an aim statement example. So if you were OHS provider, you or someone else who are doing linkage, you would say maybe something like this: by February 28th, 2026, we'll link 80% of our newly diagnosed HIV clients into care within 7 days. Same thing if you were a support service, you might say by February 28th, 2026, we'll verify 80% of our new clients are linked into care or verify that they are in care, something similar to that. So that's option 1. I'm going to hand it over to Cabria for option 2.
Good morning, everyone. Everyone can hear me? My name is Cabria Original. For those that don't know me, I am the Stigma Reduction Coordinator here at Dallas County Health and Human Services under the Ryan White's Grant Division, and I will be working closely with the CQM team to help with Stigma Reduction QIP. So excited to meet everyone and ready to get into the nitty-gritty of stigma reduction. So here today, I'll give you a basic definition of stigma and an overview of how participating in a stigma reduction QIP can help our clients within our jurisdiction. So a basic definition of HIV stigma is the negative attitudes and beliefs about people living with HIV. It's the prejudice that comes with labeling an individual as a part of a group that is believed to be socially unacceptable. And there are several different types of stigma that you can evaluate. There's structural, there's internalized, anticipated, and associative, and also enacted. I can also provide with the toolkit definitions of those different types of stigmas as well. So how will stigma reduction help within the jurisdiction? So this is some aims that we hope would happen within the jurisdiction, but there are other things that can come out of it. So some examples are providing a more inviting HIV system of care within the Ryan White network, reducing provider bias to improve patients' health literacy, and so that the patients can continue to make informed decisions about their health. Also aiming to increase our viral suppression rates within the Ryan White Care Network, and also just address patient self-efficacy on, it may be viral suppression, it may be helping to reduce their own internalized stigma, but just helping them with that self-efficacy by improving patient experiences and or providing them tools to navigate the many different challenges that comes with an HIV diagnosis. It's so nice to meet everyone again, and I will pass the next slide on to Oscar.
Thank you, Gabrielle. I think we I think we are running a marathon on this one. I mean, that we are going too fast. So far, any question or any observation on where we're going? Well, we are halfway of this explaining the quality improvement projects. And again, these are options. And what we are dropping here is ideas with a little concept behind. But those agencies who are already on the trauma-informed care curriculum and actually adopting that as a part of the culture in your work site, you're very familiar with this. What is trauma-informed care? It's an approach that is involve all elements and recognize and respond how someone can be affected by trauma, and we can resuscitate that trauma and have absenteeism on medical appointments because that doctor mentioned something or that name that he was called in the waiting area, or any detail can be a trigger, and that actually can result in absenteeism. Don't come back out of care. There will be no ongoing treatment on this individual at that specific spot. So what we are encouraging on this trauma-informed care is in learning is the staff need to be aware that someone can have, everybody can have, pretty much I think everybody has, all we have. So trauma in life that we can associate immediately when triggers, that can change our attitude, that can change our willingness. That is important to recognize that exists and to be able to provide a holistic approach for healthcare. We need to be taking that into consideration and provide the best care that everybody deserves. So give me the next slide, please. How that helped our clients? It's kind of go hands in hand. I mean, reduce stigma, shame associated with trauma. That improve retention, improve patient engagement, treatment outcomes will be improved due to the welcome piece of that individual who is welcoming that facility and make them feel safe. Important that piece. Promote sense of safety and trust in a healthcare setting. It's difficult. Why? I think we don't have to mention why the minorities, they call us Hispanic, African American, we don't trust the health system. And how can we improve that? Okay, someone who has previous experience, we don't want to replicate that because that would be the result of a bad outcome. It's the strong point to motivate individuals to learn how to cope with that trauma And later in life, those who are associated with this trauma-informed care will be addressing clients. So far, in the next slide, we will see, and give me the slide 11, please. This is, you are associated, I mean, you are very familiar with this graphic, which is the main point of the first year. The 12 to 18 months is to establish the culture in your service, culture in your clinic, culture of trauma-informed care. Provide, I mean, be aware, be knowledgeable about that, the existence on that detail in that individual heart, mind, spirit that can be detrimental for the medical care, for the social care, psychological care. All kind of approach can be destroyed if someone is not welcome or addressed in a proper way, or trigger some strong trauma that make you feel uncomfortable. So at this point, what we have learned from the directors and the coaches from CAI is that the first year is for recognizing, establishing the culture, recognizing the staff that will be participating, and there's a time element that you have your forms, you run the program itself, and we want to give the opportunity to facilitate the quality improvement project within that activity that you are actually developing. Give me the next slide, please. And here we are. This is the first year. The implementation of this model, how to approach it. The first step, and you can identify what steps you are in at this point in your agency, in your staff, the leadership engagement to secure it. Identify those. The trauma-informed education and organizational readiness. To establish really, is our agency ready to adopt that concept and be able to provide it? That's the assessment. Develop a style messaging for why trauma-informed care is important. Assess the culture, identify potential strengths. That's another step within the first year. Policies and procedures. That's within the first year to change the way you manage the situation, or manage the staff, or educate the staff. The training. That's another layer that the first year, the first 12 to 18 months, you are in that phase now. And we are trying to encourage you to take the QIP, the quality improvement project, within the thing that you are already doing. So you won't be duplicating your work. You will be doing two in one. So that's the main purpose of this incorporation of the quality improvement project, as a suggestion of Sonia and Miranda, and evolve this within the CQM as an improvement project. And then it's come the implementation. Let's say for 12, 15, 18 months, you're ready. You set the performance target. You provide skill-based services for to consumers and in an appropriate way. So what's the stage that you are in at this point? And I'm understanding that Dwight is a few years ahead, because they were kind of pioneers on these trauma-informed care processes, and they can, I mean, he can share. I hope is that okay? To share the experience you have had over time.
Yes, that's good. Thank you. We're in our fourth year journey along this very timeline that he's outlined. We started off with the physical and cultural assessments, and we learned a lot from both our clients and staff. And if you recall, one of the major things that came out of our cultural and physical assessment was our name, AIDS Services of Dallas. The clients did not like that. Now we've actually implemented a name change to ASD. So this particular survey or assessment helped underline what we have been hearing for several years, and that was the beginning of our transformation. As we went down the line, we tried some cultural enhancements, some stigma reducing things, and it was I'd say we had mixed reactions from the staff, about some cultural items. And that was the intent. It's to get those things out in front so that we could address them. We continue to work on our policies and procedures, and we're actually trying to implement some performance measurement targets that we can. We've been through the training. Let me back up. Our staff have been through the training, several different trainings, but at this point, we're at that phase of trying to measure outcomes that will be helpful for our clients. So that's kind of in a nutshell of what we've experienced along this particular timeline. This is the very timeline we've used to get to the point where we're ready to now start measuring some performance outcome measurement.
Your ID, your social.
And Dwight, may I ask you something? And because you mentioned the staff, how do you, important pieces that you are involved in the group, because it's a change of processes, it's embedded in the culture of trauma-informed care within the organization. So you're involved as much people that are part of the equation within the organization, which basically is everybody. So how difficult it was?
Well, we had a specific matter where we had a change in leadership. We had a change with our staffing. So we actually had about a 6-month pause in that window to adjust for that. But what we actually ended up doing, Oscar, was implementing our action plan within trauma-informed care. We incorporated that into our quality management plan so that the ASD corporate organization wouldn't lose the trauma-informed care aspects of what we were attempting to do during the year. So as we progressed through the year, those specific action plan goals that were in that, we made certain that we mentioned them during our quality management program to continue along our timeline continuum of attempting to hit those goals and targets. So while we had a major change in our management and staff, we continue by having the trauma-informed care action plan incorporated into our quality management plan so that it would continue with visibility across the enterprise.
But
Right.
can we ask for a mute, please?
Thank you.
Yeah, I think that's someone in the office with Dwight. If I'm not mistaken, Dwight, you have someone in the office there with you
Muted.
that's talking. Yes, yeah.
Yeah, so thank you for
Okay.
sharing that, Dwight. We're going to move on with the slides so that everyone else can have their time to cover their whatever it is that they're supposed to cover. So Oscar, I think Tavion is up next.
Yeah, and thank you, Dwight, for that observation. I appreciate that. It's something to think ahead. Thank you. Tabian. Thanks, Angie.
Thank you, Dr. O. So I'm going to quickly review the Ryan White polling results for our QIP poll responses. So out of 10 agencies, including Can Community Health, again, welcome to Ryan White. So out of 10 agencies, we have a few decided in trauma and care, 3 deciding in trauma and care, 1 with linkage to care, and 6 out of our 10 still deciding on their QIP for the year. And I will pass it on to AJ.
And we have 3 out of 6 on our side. As far as still deciding, just Abound in Prosperity, HSNT, and Prism. But we are on the road. We're getting there. We're getting there. So that's still good. We're still moving forward. As far as Stigma Reduction coming up next, that's going to be Regina.
Let's see. Okay, if I get off mute, that'll help. All righty. So, so just to share with you a few stigma reduction QIP ideas. We have one option of using the HIV-related stigma tool on patients. You can also develop a separate stigma tool for your workforce, for the staff in the office. You can also offer stigma reduction classes to your staff and or clients. You can even develop a plan for minimizing stigmatizing language. So just to give you a few ideas on that stigma reduction process. And then also during this process, we're also asking you to complete an aim statement. So an example of a stigma reduction aim statement would be by February 28, 2026, we will screen 5 patients per week using the stigma screener tool. So that just wanted to give you some options for that. And and just a reminder, before everybody jumps off the line for today, we will have a 5 question poll at the end of that. So just wanted to throw that in. And now it's back to Oscar.
Thank you, Regina. And this is just ideas. This is a set of training that that program has available for every single one. So more to come in trauma-informed care. I don't need to reinstate what you already are involved. It's just an option, and these are the trainings that this statement example will be 50% of our staff will be completing the Trauma-Informed Care 101 or any other training that is listed there by February 28, 2026. Boom. You set a time, you set a group, you set the outcome, and voila. Thank you. So let's pass to the next slide.
Well, Oscar, we actually have a question. We have a hand raised. Norma.
Good morning, everyone.
Hello.
Good morning. Good morning.
We're kind of leaning toward doing the TIC one, but I'm kind of interested. It sounds like the TIC one is going to last more than a year. Is that going to be okay with you guys?
That is correct. That is correct. Will be okay to prolong the improvement project in this case because it has different stages, different phases, and that'll be completely okay.
Okay.
Thank you.
Do we need to send an email saying we've decided on the TIC? Or do we just go forward?
We talk about that a little bit later in the session.
Okay. Thank you.
Sure. Thank you.
Well,
Any other question? Regina, we have questions?
I think we're good. Nothing in the chat. It's
the next slide.
Okay.
What the time we have on this one? Ideas. What do you have in mind? Okay, you're gonna go linkage to care in 7 days. Newly diagnosed, linkage to care, link them into medical care. We need to follow the definition of linkage, not just the referral. It's just to have the visit with a provider with prescribing privilege. That's linkage. And stigma reduction. It's more open, lenient, and you can be creative on that. We go with trauma-informed care. Based on the stage that you are, you can set up your goals, your aim, in all those details based on your capabilities, where you are in that program, and go from there. We won't abandon you. We're gonna help you as much as we can within our capabilities too. And we appreciate that call when you request some input. We try to be there as soon as possible, responding to your questions if we don't have it on hand. So, do you think in this portion of the presentation is helpful to light up? I see Norma decided more for trauma-informed care. Perfect. That's the purpose of this section of the presentation. So, what do you think? Any comment, please?
This Dwight. We did the stigma reduction using a few years back using the international truth and racial healing model, and it was received with mixed results, only because it was so confrontational. When I say confrontational, talking about cultural and racial matters, uh, it made some of our staff aware that, wow, I didn't know I had that bias, as an example. So the stigma part we found in our organization was one we had to work on, because we were definitely at odds on different matters or different truths as these models were being presented. But what we found in our third year of trauma-informed care, that the staff was actually using trauma-informed language, which was uh, had a more calming effect on our clients, just by them transforming the way they spoke to the clients. So those are two things, our observations from our experience over the years in that area that we've seen.
Thank you so much, Dwight. Anybody else? Any other comments? Having none, we pass the microphone to Angie.
Okay, before I move forward with that, so we just kind of want to help. I hope we were trying to offer some ideas that help those who are still undecided maybe move to a QIP that they would like to do, even if you don't have everything figured out yet, or at least eliminate something that you don't want to do. So if you find yourself, moving one way or another, and you want to kind of share that during the time that we have, as we end at 11:30, but we're trying to get through so we have time for Q&A at the end of the call, feel free to share that.
Yeah, we got a few folks sharing in the chat.
Okay. So
Kim,
you
go
want to
ahead.
share them now? Or you want to save them for a Q&A?
We can save them for Q&A. It's not any questions, just that that the presentation has been helpful. And Kim at HSMT is saying that they may likely go with TIC, with Trauma-Informed Care.
Okay, good. All right. So just to go over, I think this is me. Yeah. Go through some expectations for you guys and for us. So this is kind of reiterating some of the things that we've always do for the QIP, and just refresh our memories on the timelines and all that. So by the June webinar, we want you to have chosen your QIP, selected the team members that will be working on that QIP with you, and develop your aim statement. We will, for those of you who on the QIP poll said that you would want to request TA for your aim statement and PDSA, we will have to do that before the webinar in June. So it probably will be one-to-one TA, because everybody could choose something different, and then it wouldn't be beneficial for everybody to sit in on a TA that wasn't associated with what they wanted to do. But we'll probably start scheduling those in May, but stay tuned for that. And let me see, I think that, I'm sorry.
Oh, yeah.
Did I do my two? Yes, I did. Okay, I'm sorry. I'm trying to wear all these hats, and one of my hats is falling off. So let me pass it on to Tavion.
Thank you very much, Angie. So this is our regular cadence for the QIP calendar of 2025. So starting with today's webinar, you're going to go through every few months action period, whether you're working on a process, your QI project, or any form that you just need to have submitted. And then followed by each action period, we conclude at the end of the year with our World AIDS Day poster symposium. Just for each agency to present what their plan was for the year for the most part, and anything else moving forward. Thank you.
Appreciate that, Tavion. Oh, yeah. So jumping over to a couple due dates for us I'll probably put on you guys' calendar as well, Ryan Whiteside. I think you guys, you'll get it from Angie, I believe. But as far as June 15th, you guys have seen this before. Most of you guys have seen this before. The root cause analysis form is due, along with that PDSA worksheet. And then September 15th is that follow-up PDSA worksheet, and then December 15th. So we try to keep it around the 15th. So when the 15th hits, if you notice Dallas County, 15th is our day. So something should be submitted for Dallas County around the 15th. So that's the dates for that. And then go to the next one. As far as reporting additions in support of the Part B statewide linkage, for QIP, that's still a thing. Sharebacks of PDSA worksheets. Use quarterly submissions to provide individualized TA and generate the background for the capacity building series over the year. So again, we're here to support. You're not doing this alone. Creation and delivery. Creation. I made that up. Creation and delivery of QIP capacity building series. Provision of individualized TA related to the QIP and internal collaboration efforts across all of us so we all can support each other. So with that being said, I'll pass it back to you, Angie.
Thanks, AJ. All right, so we're going to talk a little bit now about our framework, which is our QIP life cycle and using the model for improvement. So our life cycle, so we think about at the bottom, you see the assess, the diagnose, and intervention. So that's what we're doing through this life cycle. So we're going to, assess the problem, assess the situation, diagnose the problem, and then we're going to do an intervention. So the discovery process is just that assessment piece. We're looking at what is it that we have, what's going on, what data, what evidence, what we like to change. We move next to the root cause and the change idea. So the root causes, that's part of your root cause analysis, the RCA. When you kind of look at what the problem is and how can we address it, trying to get to what is the root cause of the problem, which leads to some change ideas. We think about the PDSA form we'll talk about in a little bit, that we're going to test that one change, one thing we'd like to implement to see if we can, help us to accomplish our aim statement. That one thing that we pilot, that one change idea, and see how that goes. And from there, we do other things based on what the evidence bears out. So the model for improvement, we talk a lot about the PDSA, which is very important, but the model for improvement is just as important. And so those 3 questions there in the top right, that's over the PDSA cycle. What are we trying to accomplish? That's our aim statement. That's what the aim statement answers. So we need to use those 3 questions first. And then depending on what answers we get for those, that can change the answers for our PDSA. So the questions plus the PDSA cycle makes up the QI project life cycle. So when we say, what are we trying to accomplish? We're using that discovery, we're setting our aims there. How will we know that a change is an improvement? From those, what we learned in discovery, we're going to set measures, because we have to be able to measure change. We can't just say that it is a change. We have to start with the baseline somewhere, be able to measure, and then whatever we do with what we implement, what our intervention is, we remeasure at some point so that we can see that change happened, and then what change can we do that will result in an improvement. Because sometimes we make changes, but they don't necessarily improve things. So we want to try to make sure that we're making changes that lead towards improvement. So those change ideas are the root cause analysis stuff that we look into. We're taking that into account. So we're trying to move toward that, the root cause of the behavior or the change, not just anything, but what is it that is causing this problem? How can we impact or improve this problem? So once we identify a change idea, we want to test those changes. We want to pilot them on a small level, one provider, one day, and then we try to, if it's working, then we keep going and we expand it beyond one day or one provider type of situation. But the testing those change ideas is the implementation phase of that. And so now I'm going to pass it to Oscar to go a little bit more in depth. And some of these slides may seem redundant, but we are kind of reiterating that, making sure that we're capturing what we're trying to do when we do these things that we're talking about, and that you are capturing them when you're filling out your PDSA tracking forms and, when you're doing the process yourself. Because sometimes I think we start completing paperwork and we forget what it is that we're ultimately trying to do. So I would say too, when you're doing your PDSAs, read them, write them and read them like you didn't do them, so that someone outside of your organization or us or someone else reading it will know what's happened, because it's really easy when we're doing the process, we know what it looks like, and so we're putting all this stuff in here, but we need to, I think, sometimes look at it from another person's perspective to make sure we're telling the story that we want to tell, to make sure we're connecting all the dots. Does our PDSA link to our aim statement, which is that showing that what we did for our QIP project. And now I'm passing it to Oscar.
Thank you, Angie. And this is usually stating that what Angie was mentioning on that. This is the three questions that need to be in our mind, in our paper, when we are implementing this process. What are we trying to accomplish? That's our aim statement, our goal, and our goal of the improvement effort. You can establish a clear objective, but an objective that everybody involved in the process understand and participate. Make them feel like this is owned by us. This is our project. This is something that we want to do, not just one or two people doing the full paperwork on that one, because that will be probably not that effective. And sometimes that involves some specifics on outcomes and timeframes and the people that you want to target, so everybody will know that's what we are looking for. This specific population we are addressing in time, and what will be expecting out of this one. You're establishing the outcome, and but the testing. How do we know that change? It's really an improvement. Is measurement. Again, CQM is measurement. And everybody, I think in everybody's life is connected with the measurement. That could be an outcome measure, that could be a processes measure, or could be a balance of both. So this is, again, it's open and be creative on this. And PDSAs helps to test in a small scale, some changes to improve some process or improve some outcomes. This is small scale that we can test and identify really if that works. And we're going to implement this process into the regular practice. That's the main purpose of the whole PDSA, if that small scale really is applicable to the big scale, and who else is being affected by it. We need to have the whole picture in mind. That change will happen in this time frame. It is good outcome. Let's implement this one as a best practice in our clinic, on our service, on our office, on our any service that we provide, and evaluate who is impacted by it. Within the agency, who else is involved that didn't know is involved, because the process will be affecting who. Just having the big picture of the situation when you create an improvement project. So main ideas, it just clarifying what Angie was mentioning. Give me the next slide, Angie, please. I think that is.
And that'd be me, Oscar. I appreciate that.
Yes.
So practical application, guys. So when you
Thank
think
you.
about it, if you're familiar with PCN 1502, that's kind of still what we go off of as far as expectation wise. So along with the model for improvement. So we'll continue to use that method. So if we could, Angie, let's go to the next slide to take a look at what we're going to be doing between now and June to make sure we're all on the same page. All right. So 3 strategic questions. Go up. You got, as you see, three strategic questions followed by PDSA cycles. So remember, the model for improvement is what is going to be said a couple times. That's what we're going off of. So we're all on the same page. It's 3 strategic questions plus the PDSA cycles. So please review the bullet points and then how do they align with the three main phases of the QIP life cycle mentioned earlier in the presentation? So that's kind of what we want to keep in mind when we're thinking about the model for improvement. And then Angie, if you go to the next slide, it's our same model for improvement diagram that you keep seeing. Again, this will go off of. So remember, this kind of
Hey, I'm sorry.
expectations. Go ahead.
AJ, what slide number are you on? Because I think I missed one.
We should be on we should be, the P is for plan. Yep, you're on the right page.
Okay.
So this is correct. You're on the right diagram. So again, the three strategic questions, and we begin with the P phase of the PDSA before the June webinar. So any questions so far? I think we're good. Yeah, otherwise we're still going. D'Angelo, I'll pass it over to you.
Yeah, thank you, AJ. You know, just wanting to start off with the P phase, right? I feel like the P phase is very important. P for plan, it's really the foundation of your quality improvement journey. So to just go further into breaking that down, one of the things that each organization needs to do is establish a SMART aim statement. A lot of you guys are familiar with doing this already. Something specific, measurable, achievable, relevant, and time bound. And this statement is going to guide your whole project and be a crucial part of your PDSA worksheets. The AACQM team and EHE teams both are here to help you and shape your aim statements and provide resources throughout this whole entire process. But then after that, next we'll have the discovery phase and root cause analysis. And this is where we ask what exactly is happening in your organization. What's preventing the ideal outcome for your clients? We want this part to be unique to your specific population and then not just like a copy and paste solution. So we want to think about what data do you have already? What insights came from past client feedback or performance measures? What internal or strategic planning documents can help you guide your focus? From there, we want to talk about our root cause analysis and then asking you to just dig deeper in what's really driving the issue. Some of you guys are familiar with using tools like fishbone diagram, the 5 whys, or other types of process maps that can help uncover those things we're looking for. And then think about your RCA stakeholders. Who might that include? That might be case managers, your clinicians, your data staff, your clients, pretty much anybody that can help identify the why behind the problem and should have a voice in this phase. And lastly, I just want to give another reminder that the RCA form is going to be due June 15th. So we'll have plenty of time between now and June 15th to really explore and understand the issue that you guys want to address at your agency. Thank you.
I appreciate that, D'Angelo. So here we're sharing with you the quarterly PDSA forms. Both Ryan White and EHE subrecipient sites will use this form to report on your QI project quarterly.
Can't hear what he's saying if he's trying to talk.
Yeah, your mic is sounding a little bit muffled, Tavion.
Can anybody hear me now?
Right.
A little bit better.
Now.
Yep, that's it.
This is better. Excuse me. So like I was saying, here we're sharing with you what the quarterly PDSA forms look like. Both Ryan White and EHE subrecipient sites will use this form to report on your QI project quarterly. And at this current moment, the Ryan White form is being revised and will be available to you at the near future. Thank you. And I'm going to give it back to Miss Regina.
Ready? Thank you, Tavion. So just for the use and just a quick recap for everybody, as Angie and AJ mentioned about the use of the model improvement. So we also have the upcoming webinars, and I think Tavion went over those, but we're going to remind you here. The next one will be Tuesday, June 17th. The 15th falls on a Sunday. So we're going to work for that, set that date for June 17th. Our August webinar will possibly be in person. That date has not been decided yet. Maybe our coaches will be able to join us there. And then the next one we're aiming for Tuesday, October 21st. And as on our Dallas County, as far as offering any TA or any specific support that your agency may need, we will be reaching out to those who stated that they would like assistance with creating their AIM statements and their and working them through their PDSA. And as Angie mentioned, we'll reach out for one-on-one to set up one-on-one appointments with you, and we can move forward from there, and especially before your first submission on June 15th. And now I'm handing it back over to Oscar, Dr. Salinas.
Thank you.
For our Q&A.
Here we are, an open field to discuss questions, answers as much as we can, as much we have it on hand. Yes, if we don't have it on hand, we put it in writing and get it back to you for sure. So any question, any observation, I want to hear your opinion about that. How do you feel with the options and brainstorming?
All right, Sangeeta has her hand up. Go ahead.
Do. Hi, Regina. Hi, everybody.
Hey.
Thank you for the presentation. I really appreciate it. And I think that this is something that I can at least provide to our QIP team members as to like what we should be looking for and what to look out for. One thing I mentioned in the chat is like being able to have more of a real-time communication channel in some way would really help me a lot. So like utilizing the features that are available through Glass Cubes, because we do have like those pages designated for, you know, our own agency versus like all of the subs together. I think that that would significantly help me a lot, because I don't know about anybody else, but June 15th sounds like really far, and then June 15th happens and it's like immediately, and then you feel like you're behind and it doesn't really like help with the cycle of improvement, right? For me, it takes a lot of small steps to make these kind of big messages like or goals happen essentially. And I totally, yeah, I agree with Jamie, and I know what you're talking about. I think it's just more so like, can we just like all kind of engage on that just so it's like all there in one place and I don't have to like dig through my email for a lot of this stuff. I think that that can be the hard thing sometimes when you're trying to get this cycle of improvement going and ready, and then I have to refer to like a bunch of different emails or polls or documents, and that's okay, but I just kind of like would appreciate one place to like have it all in, if that helps for feedback.
Thank you. Thank you. Noted.
Yeah, because I was doing the presentation, I could not see the chat, so can you elaborate?
Oh, Angie, you're sounding a bit far away now.
Can you hear me better?
It's coming along. It's getting there. It's getting there.
We have new computers, y'all, that are not new. That are not acting new. Can anybody hear me better?
Yes, that's
okay.
better.
We have all kind of volume issues that with our team with these new laptops. But I was saying that I was doing the slideshow, so I could not see the chat. So I wasn't sure exactly what Sangeeta is referring to. So could she elaborate on that?
Oh, sure. I mean, I was just talking about Glass Cubes and like using what's there to be able to communicate about like if there's TA or like someone needs to leave a comment or like something needs to be addressed and like followed up through a meeting or something like that. I think for me, getting that in more of a real time and less of a telephone kind of effort through like email or snail mail kind of deal is like more efficient for me, especially when I get notifications for Glass Cubes. So like I'll see that email and be like, oh, like I need to check it or I need to do this, or this is like my cue to go and make sure everything's covered for whatever issue there is, right? That's more so what I meant, just like general communication for like QIP and that type of thing helps me significantly, because then I'm not like, oh, like it's June 15th and we're scrambling. That is what I don't want to happen, and I'm sure a lot of folks don't either.
Okay, I hear you now. Can y'all hear me?
Yes.
Okay, so I would say that that's a great point, and that's definitely, I would say, a stretch goal, because this is, I think, the challenge of us being in everybody in the workforce now. We have several generations of people, and I'm on the generation of like email is where I go for everything. And then some other people are like, I would rather, like you said, Sangeeta, I would rather have this be here. See, and I would have to go there to do what you're doing. And now we have, we used to just have email, and now we got like 15 places, we got 11 places that we look for stuff. So yeah, we could streamline it and maybe make the email and maybe Glass Cubes, our main places, maybe that can help all of us. But just, not, and being transparent, that will take me a minute to do that, because I have to remember, like, oh, we got Glass Cubes, oh, we got SharePoint, oh, we have this, we have Miro, we have, all these different places. But yeah, thank you for that, and that is certainly something that we'll be working to do.
All righty. And Norma, you had your hand up.
Yes, I did. In the chat, and I think it was Jamie, talked about a subrecipient folder. I kind of like that idea. But I'm with Angie. I use emails 99.9% of the time, but it would be nice to, just in case I can't find an email, know that email went to a folder. It would be like a backup to the emails. And so I think that was Jamie that came up with the folder idea. I kind of like that too. But you're right, Angie. I'm used to the emails. I get lost when I can't find them. So that was just my comment. Thanks.
Thank you, Norma.
Thanks, Norma.
Anybody else? Thanks, Norma. I think that's a great observation, and we can explore that system.
All righty. And Stacy McNeil has her hand up.
Hi, my name is Stacy. I'm from. Sorry, I think I muted myself. I'm from Can Community Health, and I was just curious. I am not familiar with Glass Cubes. Can somebody explain this and how we might get added if that's just not something we use in our organization?
Yeah, so we will probably have to reach out to you guys before we have our whole AA staff come and do orientation with y'all to let y'all know where that stuff is. I think you have to get Regina. It will have to send, so you'll get an email from us where Regina can ask who all needs access to Glass Cubes, because we have to send that to CQII or someone, and then they approve it, and then we can give you, grant you access. So everybody will have, every subrecipient has a folder. So it's true on the EHE side and the Ryan White side. There's a lot of stuff in there for everybody, and then your quarterly submissions are broken down like by folder. Like we have a QIP webinar section, and it'll be broken out by the month, and then like the performance, the slide presentation will be in there, like the chat will be in there. This recording will be posted and uploaded to YouTube in the near future. The items we mentioned for like the toolkit, those will be in there. So Regina will get your agency information. She'll send you an email and get y'all set up with that. And just for everybody on the Ryan White side, the toolkit is nothing's in there yet, but we're going to start putting stuff in there. And then like some of the tools that we mentioned, I think Cabria mentioned for the Stigma Reduction stuff, that there are some tools in there that you can adapt for if you decide to use them. You don't have some of them for like housing and, other stuff. Some may be specifically related to HIV. But they're just things that maybe can help you on your journey to get to where you want to go with your QIP.
Yeah, great question, Stacey. Thank you. All right,
David. We're gonna guide.
Oh,
just one. I'm sorry, Regina. We're gonna guide the CAN Community Health in a closer. We're gonna have you in a closer distance, because you need to get familiar with what we are doing and what everybody is doing, so you could be in tune for the system, such as Qualtrics, Glasscube, so those kind of things. I mean, don't worry, we'll be addressing that soon. Thank you for that observation, though. I'm glad
we did have a question.
No, so just for Can Health, I'm currently working with the leadership
we're not trying to because Can Health is a new subrecipient, we don't want to overwhelm them with everything all at once. So we're creating it. The program team is creating a strategy where we can step by step guide them through the introduction of programs, fiscal, and CQM. This will be all done in the next several weeks and months, so that we don't overwhelm our new subrecipient. So just Stacy, hang tight. We're working with the leadership so that we can slowly roll this out for you guys. All right.
That sounds good. Thank you.
Yeah, and this is David Kim, who is part of the program monitor and organizing that onboarding process. Any other comment, any other observation, any question? If
So
not,
questions
go ahead.
for me, just so too. So if you already know what you're going to do for your QIP, you would just send your report in on the 15th, but we have to go and tweak those. So that's what's saying for the one-to-ones, the people who requested one-to-ones, we'll do the one-to-one TA on the aim statement and PDSAs, because we will have to update the QIP metric, the performance measure report that you send in, that has the quantitative measures on it, and then it has the QIP metric. So like for Norma's question that she asked earlier, like if an agency knew that they were doing linkage to care, then they probably don't have any changes for anything, and they could just submit their stuff on the 15th. If somebody was doing something aside from linkage to care, then we're going to have to do some things in addition to meeting with you all on the 15th, before the June the 15th, we're also will have to meet with y'all and then customize or, edit, revise your forms, your reporting forms. So it's just some more steps that have to take place before the June submission, which happens is due the day before our next webinar. So it's just going to be a real busy time for us and for y'all too, if you choose linkage to care. If you choose stigma reduction or trauma-informed care. Did we see the slide that had the due dates on it? We saw that.
Yes,
Okay.
I went over that. Yes.
Yes, we did.
Well, the other one with the root cause. Yeah, AJ, you did that one because I thought I had skipped a slide.
The 15th. Everybody, the 15th. 15th.
Okay.
15.
All right. So everybody saw that. So you have your root cause analysis form that's due and your PDSA form that'll be due on the 15th. And did anybody have any other questions related to any of the stuff that we just discussed or something that we haven't talked about?
How about we roll the poll?
I do have one quick question.
Sure.
Go ahead.
Hi, y'all. So June 15th is actually a Sunday. So would you like it on Friday the 13th, or will we be given grace till the 16th?
Yeah,
You'll
it'll be
grace to the 16th.
Yeah, it'll be June 16th.
Yeah.
And when we send out the PM reporting forms, it'll be updated on there for the actual dates.
Yes.
Awesome. Just wanted to double check, make sure we're prepared. Thank you so much.
Yeah, anytime that the 15th is on a holiday, on a weekend or something like that, it'll be due the next business day.
Okay, appreciate that, Angie.
You're welcome.
Awesome. All right, everybody, we are ready to start our poll, and you
I'm sorry, really quick. I did want to mention, you can turn it in earlier. You do not have to wait until the 15th. You're more than welcome to submit it earlier.
Awesome. Okay. My recent polls, and it should be 5 questions coming up. Oh boy. Okay. Didn't change that. I don't need to change settings.
And Regina, I don't know if you're sharing your screen. I don't know if you need to do that.
Yeah, let's see. It automatically does that. Stop sharing. So let's see.
Yeah, I was getting ready to mention that too, because it kicked out of the slideshow.
Okay. And wow. It will not show the poll. It will not allow me to.
Did you say
Are
you
you the
had to do it
organizer?
first? You said you had to do the poll first before it let you show it when we tested it. Do you remember what happened?
Don't know. It's
Yeah,
asking
because
me.
we've been doing this. We've been doing this on Zoom, and we switched to Teams. That's what we reoriented you guys to that earlier in the slideshow, and we've tested this a few times to make sure it worked. And of course, when it's time for it to work, it's not working.
Not working.
And
Yeah.
you are the organizer, and you have to give permission to Regina as an organizer or presenter.
Try to paste the link in the chat, Miss Regina, if you can.
Copy link in tab. Okay. And let's go here. Chat. Stop sharing and chat. And here. Paste. And there we go. Let's see. Try that and see if it came through. Did it drop in the chat?
It's showing there. I'm trying to open it. It's just waiting.
Oh, here we go. I think we're in business now. Hold on. Something said launch.
There we go.
There we go.
There it is.
There we go. So you should have 5 questions there. This meeting and discussion met my expectations. Will you advance through there?
Miss
And
Regina?
Yes.
When I click view poll, it says there was a problem reaching this app. Please retry. So it shows view poll in the chat, but when you actually click on it to view, I don't know if anybody else is experiencing this. It says problem reaching the app.
Okay.
Yes.
So it's not opening.
Lauren and Stacy says they won't open.
Okay. Let's try this again then.
So Sangeeta is saying you have to add polls. I don't know who that's for. If that's for you, Gina, or everybody. Who's that for?
For everybody, I think you have to enable polls on your teams. That's what I've done before.
Oh,
yep.
Okay.
It's showing it's blocked by AHF. It's not something you're doing. So you're right, Sangeeta. It's internally blocked by our network.
It's internal blocking. Oh, wow. From you guys in.
Yes, ma'am. It appears that way on my end anyway, just for me.
Okay. Well, I tell you what we'll do then is send it externally in an email and where you can send your results. I apologize. We do apologize for that. Was not expecting that. You're welcome. Alrighty. Well, if there is nothing, since we're unable to complete the poll, Angie, do you want to close out or?
Yeah. Anybody have anything to say before? Any comments or questions or anything before we wrap up?
I just want to say thank you. This is Joni. Really appreciate kind of this refresher. I know we've been doing this for a while, but it's nice to kind of go over again, sort of the aim in the PDSA and sort of that cycle and just the kind of the step-by-step for everything. So thank you for doing that review today. It certainly was helpful with everything going on. It's nice to kind of reorientate myself to that. So appreciate your time today. Thanks.
Thank you, Joni.
You're welcome.
Thank you. Thank you. All righty. And Cheryl, thank you for that. It allowed you to complete it. So we'll if I'll do the count, and if you're not included or we didn't collect any, I will let you know via email. Thank you, Cheryl.
Okay. So before we do leave though, so I think how many Tavion and AJ, has anybody kind of that was not decided kind of moved a little bit or feel like you have some information that you can take to your team to help you move, or for any of the people that were trauma-informed care project possibilities, do you have to go to someone else to talk about doing that as a project, or are you as a CQM lead responsible for that?
This Dwight, we plan to do trauma-informed care, and I will go back to the team to review the aim statement.
Okay, good. Thank you, Dwight. Okay, so Sangeeta's saying there's going to be a lot of project delegation steps we need to hash out for trauma-informed care, which they're most likely to go with, and that she is too going to have to go back to her team with lots of components for success. Thank you. So Norma saying she think they decided on trauma-informed care, Cali Clinic, Piper will take info to the team. We are juggling Part D communities of practice. CQI, yeah, a lot of stuff going on with Parkland, CQI initiatives. So they want to try to align something with what they're already doing. So yeah, we understand that. Brooke, Legacy is interested in trauma-informed care. We'll reach out following trauma-informed care leadership meeting on the 29th of this month to set up TA. Stacey, Ken Academy, Ken Community Health, my goodness, forgive me. Ken, interested in linkage to care. RCD, Lauren, we're deciding between trauma-informed care, linkage to care. And then Piper saying if trauma-informed care with CAI is encouraged or expected, then they might shift. And we really have enjoyed working with Cabria, so likely stick with that plan if possible. Sounds like Piper's leaning towards stigma reduction. Okay, and Norma saying again, the presentation was very helpful. So we're glad to hear that. All right, so sounds like some people have gotten some information to kind of help you make your decision. That's what we were hoping to accomplish. So we're happy that we've done that, but we are understanding that we weren't able to, connect all the dots, and there are still some little gaps and stuff, and some little, waiting for us to develop things on our end, to put in the toolkit and, updating the reporting sheets and stuff. So like always, so once I usually send a follow-up email with the slides or with a link to the slides, with, a link to the toolkit and all that kind of stuff. So just stay tuned for that. Like Sangeeta said, because we've been saying that too, June seems far, but it's not that far. But let's just try to, do the best we can and not worry too much, because we got a lot of stuff that we're all worried about in this climate that we're in right now. And we'll just work together and, do what we do. We all do good work. We appreciate y'all so much. If y'all have anything else to say, then we can end our session for today. It's, I guess, the last call for anything. Sangeeta has a question. Go ahead.
Yeah, I was just saying, similar to how we have the option to send out the meeting for like performance measurement review or like quantitative versus qualitative and polls like that. I was wondering if like we can open up this opportunity in the future, maybe to have the QIP be available to our other team members if they're interested in learning about it. Because a lot of the time people will ask me like, oh, what goes into our PDSA? What is a PDSA? That type of stuff. So I think they're also interested, at least on our side with our org. So just a thought.
Yeah.
That was great. That was great. I mean, peer-to-peer review. That is
right.
That is fantastic. Yes, indeed. We'll put that in a in a basket in the projects to go. Thank you.
Yeah. And just to wrap up on my end for the poll, Angie, we were able to collect 8 responses. So if you receive the email invite, you do not have, if you were able to complete the poll, you do not have to do it again. Thank you.
Great. Thank you.
Thanks, everyone.
So we're all good for today, Oscar? We're good?
Yeah, we are totally good for today. And I mean, I want to give you the pleasure of goodbyes for everybody, and see you later. See you soon. Hope to hear from you soon. To Angie, because she's the one organizing this event. And congrats, Angie. You're doing a great job. Thank you very much.
Thank you.
Very well
Thank you.
done.
Thank you.
Thanks,
Bye.
everybody.
Have a good day. Bye.
Thanks,
You as
everybody. Have a
well.
good day.
Thanks.
Bye-bye.